We are presenting a case of a 50 years old lady who came to us with very low visual acuity, presenting with a white cataract, partially resorbed, things that could be seen both in a slit lamp examination and on UBM. The B scan performed showed no significant findings, so we proceed for the surgery. Our main concern was, is the posterior capsule is intact or not? The UBM performed before the surgery didn't reveal significant findings. So we just started and decided to see step by step what is to be done in order to do the best surgery for this lady. Of course, we dyed the capsule, or what we think is the capsule. It seems that both anterior and posterior capsule were stuck together with some cortex partially resolved between them. And after the dye, we dye under air in the anterior chamber, and after the dyeing of the anterior capsule, we started the capsulotomy with cystitome, with a bent needle, and then we continue with capsulorhexis forceps. We don't know exactly where the plane or of the anterior capsule is, but we try step by step to perform at least a continuous capsulorhexis. And in the right side of the image, it was not possible. We stopped and continue on the other side, again with the cystitome, and then with the forceps. And it seems that at the end we obtain a pretty nice capsulorhexis, round, and it seems that it was even continuous, so a correct capsulorhexis. The next step is to check what is between the two capsules behind the anterior capsulotomy. And we try first to perform hydrodissection using Akahoshi cannula, with very, very small quantities of BSS injected in several points, very close to the equator. But it seems that white material did not move at all. We found a break in the fibrotic material in the center of the bag, and there we try to inject there first BSS, then methylcellulose, in order to create space between the two planes. The central break was too small, so that's why we wanted to enlarge it. It seems that immediately after the anterior capsule, which was thin and it was removed at the beginning of the surgery, as you saw, it seems that behind it, it was very thick white fibrotic material, which needed to be removed as well. But it was so thick that it was not possible to remove it without cutting it. So we start to cut it using a VR forceps, and then again start to wash, to aspirate the white tissue between the two capsules. We were not able to aspirate anything. At this point, some material seems to be possible to be aspirated. And then we decide to continue with this round window in the thick white material that we have behind the anterior capsule. We managed to have sort of window, but because the VR forceps was too thin for this thick membrane, we decided to use the Vanna scissors. Otherwise, it was not possible to cut it. For that, we needed to enlarge the incision, and we continue the cutting of this fibrotic thick tissue with the Vanna scissors, attempting the cutting from different parts of the anterior chamber, both from the paracentesis and from the main incision as well. At a certain point, we needed to perform another paracentesis at 6 o'clock in order to use the scissors through it and to cut this thick white membrane towards the 11 and 12 o'clock position. We wanted to enlarge sufficiently this window in the fibrotic white membrane to create a space, at least for a visual axis, to set free the visual axis of this eye. Of course, the video is a bit fast-forwarded because in reality it took some time to cut on 360 degrees this thick membrane. At the end, we managed to make a window, let's say a round cut of about 3.5–4 millimeters, which we considered enough for a visual access for implantation of an PC-IOL and for a functional visual axis. In the left part of the bag, it seems that the cortex is softer a bit and it could be aspirated. The posterior capsule was there, so we were happy that we will be able to implant an IOL in the bag behind this thick white membrane, but on the posterior capsule. Unfortunately, on the right side of the eye, the things were not like we expected. It seems that on the posterior capsule there was another thick white fibrotic membrane, which needed to be removed as well. And it was impossible to do that without cutting it with scissors, with the VR scissors. But this membrane was stuck together with the posterior capsule, so we realized that we could not do other than remove both the fibrotic membrane and the posterior capsule. Now we have a nice visual axis. We perform minimal local vitrectomy, which is not shown in this video, and because we were not sure what is behind the white ring of fibrotic capsule, if the peripheral posterior capsule is enough, we decided to implant the IOL on the anterior capsule and on the anterior fibrotic white material. And because, again, we didn't want to create too much force release while unfolding the IOL, we preferred to enlarge a bit the incision and to implant the IOL unfolded in the sulcus. It is Alcon 3 pieces IOL with a length of 13 millimeters and optic part of 6 millimeters, which was implanted and stood very well centered behind the iris on the anterior and posterior capsule stuck together. After implanting the IOL, we injected myocol in order to constrict the pupil. We finished the surgery with a little bit more of vitrectomy in the anterior chamber, just to be sure. And this is how the eye looked the first day. The pupil was a bit up, but that was before the surgery. Still, the patient had enough free pupil to have a good visual axis.